Good morning. Yate Che'e Savannah Jean Yanishya. I am in the U.S. My name is Savannah Jean, and I work with the Albuquerque Area Indian Health Board. I am the moderator this morning. I would like to first start off this session with acknowledging the traditional 476 million Indigenous peoples living in approximately 90 countries across the world, representing around 5,000 different Indigenous cultures. We want to especially acknowledge the unceded land of the Indigenous peoples of the Yelamu in San Francisco, the Ramaytush Ohlone and Hoichen, the Confederated villages of the Lijan Ohlone peoples in the U.S., neighbored by the Moikma Ohlone, Costanona, Asalin, Rumsen, and Mutsen Ohlone. This is where the conference would have been prior to COVID-19. There is simultaneously interpretation into French and Spanish throughout the session. Down on the bottom left, you can switch languages to French or Spanish. And a reminder for our presenters to speak slowly and clearly and allow for a 3-second pause before we respond to any questions. The interpreters, thank you for this. Just a few notes about the functionality of the platform. There is a messaging section where you can see messages and chat from all the individuals who are participating in today's session. Also, there is a participants tab where you can see all participants and can be used for discussion with the audience. And for our presenters, if you could request to speak and we could admit you. We have several presenters joining us today, and they have recorded presentations. If you see on the side, there's a section for the polls. That is how we will be conducting the evaluations. And there are several questions in the polls. If you could please remember to complete that at the end of the session. And this can be done at the end of the session. There's 3 questions. And again, just access it by clicking polls. We have our recorded presentations, and these will show it in the box marked video. So this session is also being recorded and is made available you can access it through the website for the International Indigenous Pre-Conference on HIV and AIDS. So today's session is Diverse Indigenous Responses to HIV, India and Canada. Each Indigenous community has the right to lead their own response to HIV from the grassroots community level to the national level, utilizing Indigenous networks. In Andhra Pradesh, India, due to the poor health infrastructure for Indigenous peoples, high levels of poverty and lack of awareness, many Indigenous communities are exposed to various health issues, especially communicable disease, including HIV and AIDS. The second half of the presentation will feature an interactive workshop with an extended question and answer period. This will not only allow the presenters from Canada to explain the SPIRIT tool and how it was used for the Canadian Aboriginal AIDS Network, but to share CAAN's messaging and advocacy strategy, as well as demonstrate to their international partners how they may benefit from lessons learned. A 1-page guidance document related to the road mapping process is to be shared within the context of the series of webinars with the goal of sharing best practices, communications tools, and to promote national and international partnerships. So our first presenter today is Akila, and I apologize for mispronouncing the name, Akila Rajasru Ganju. The title of her presentation is Case Study on Prevention and Care of HIV/AIDS tribals in India. She will discuss data and findings from a case study on HIV/AIDS in tribal communities in India. Banju Akila Rajastri is 20 years old, born in an Indigenous community and living in a remote forest area in Kandrakota village in Andhra Pradesh, India. She studied a bachelor's degree in computer applications and has been involved in social service since childhood. Her father, Ganju Anikkumar, was running an NGO for Indigenous peoples' welfare activities, and Akila has done awareness camps for Indigenous women regarding prevention of HIV/AIDS in Indigenous people in her villages and doing work on bringing awareness to the prevention of domestic violence in the Indigenous families and other livelihoods improvement in poor Indigenous communities. So we will be watching her pre-recorded video.
Hi, greetings everybody. My name is Akila Rajeshri, Indigenous leader for ICWA Network. I was born in Indigenous community, Koya tribe in India, and living in remote forest area in Kondukota village, Andhra Pradesh, India. I studied a bachelor's degree in computer application and has been involved in social service since my childhood. My father, Gangu Anil Kumar, was running an NGO formed by Indigenous people and working for Indigenous people's welfare activities, and I've been part of awareness camps for Indigenous women regarding the prevention of HIV/AIDS in tribal villages and doing work on bringing the awareness to the prevention of domestic violence in the Indigenous families and other livelihoods, improvement in poor Indigenous. We're happy to introduce our NGO, Integrated Tribal Development Society. ITDS is a non-governmental and non-profitable voluntary service organization formed by Indigenous people and working for the poor Indigenous families. Our vision is to reinvigorate the Indigenous culture, identity, and environment through socio-economic, cultural, and political participation. Our mission is to promote the indigenous knowledge systems on the health education and culture primitive and corrective health cause in case of immediate cure and support. Regular information of collection of health issues of indigenous people regarding malaria, viral fevers, tuberculosis, TB, HIV/AIDS and COVID-19, and in case of immediate support, we have always illusion with the local government and hospitals and health department and working for this indigenous health. We have conducting HIV/AIDS awareness regarding the prevention, identity and dropout indigenous children and encourage to joining them in the government schools through free distribution of school books and school bags. Our achievements are improved prevention, knowledge of viral fevers, STI, HIV, AIDS, TB among the indigenous families. We have done the advocacy and provided the displacement compensations by government for the indigenous people who lost their lands in dam constructions. We have supported for poor indigenous students through the free distribution of books and school bags. We have done the behalf of advocacy of indigenous families to get the Forest Right Act's lands, and also our future plans are to provide the socio-economic support for poor indigenous people infected and affected indigenous families of HIV/AIDS, COVID-19 and deadly diseases. HIV/AIDS prevention, education for indigenous people, livelihood, and support for indigenous and displaced families. Climate changes programs with the participation of indigenous families are the things which are being done, and my presentation is prevention and care of HIV/AIDS tribals in India. The tribals on their own never catch the HIV/AIDS, STDs and TB and COVID-19 The spread of disease, it is the only when the outsiders such as business peoples, tourists, migrants, problems and displaced problems and others who visit their areas, they live behind such problems. So tribal areas already suffer from severe shortage of basic healthcare facilities, shortages of healthcare professionals, lack of information and awareness, etc., leading to the prevalence of lack of information and awareness, etc., leading to the prevalence of diseases such as malnutrition, malaria, leprosy, and TB, HIV, AIDS, and the COVID-19 and others. The absence of healthcare facilities can severely limit the capacities to deal with any measure this situation. Severe limit is there for the tribal areas posing a serious threat measure with this situation. It impacts the people with the compressed health conditions and low immunity. This increased risk of infection to the tribal and forest communities living in the deprivation. Testing and monitoring of disease is inadequate and is mostly limited to the urban areas. Providing testing facilities in tribal areas is a major challenge. Mainly, HIV/AIDS is transmitted through various ways: sexual contact with the living HIV/AIDS, peoples without the prevention methods. HIV/AIDS could be transmitted through the needle sharing and unsafe blood and mother-to-child transmission, and if the mother is infected by HIV/AIDS. In Andhra Pradesh, the distance of these tribal villages from Mandal headquarters determine the awareness level regarding HIV/AIDS. Also, in the villages adopted by NGO, and the awareness level of the tribal communities was better than those without their NGO presence. As compared to the other study, states of awareness level among the male and female tribal people has high in Andhra Pradesh. With regards to cause, the prevention and treatment, this was mostly true of villages with NGO presence and this of close to the Mandal headquarters. They believe that HIV/AIDS is preventable and even curable. This is reflected from the quote below. It can be definitely prevented. It can be definitely prevented, and as such things that the usage of condoms and specialized strings should be used for new strings should be used at the time of blood transfusion, and good should be tested. If the HIV infected mother takes the medicines costing rupees 2,000 per day till the time of birth of the child, the chances of AIDS being transmitted to the child are reduced. It's only a blood and the sexual activities by which the disease is transmitted. The misconceptions about HIV/AIDS. The misconceptions reported by tribal communities were in the line with the misconceptions of the general populations reflected through review of literacy. General population had misconceptions on the mode of transmission. These included the misconceptions that can be spread through mosquito bite and sharing of meat with an infected person. A study amongst tribal people found that out of 22% of people who had knowledge about the HIV/AIDS, and 1:7% believe that since would get the AIDS and STDs can be permitted, and sterilization of women. AIDS is required by looking at an infected person who has AIDS for the HIV, according to the study on the assessment of vulnerability of rural population of HIV/AIDS in rural areas. Several myths and misconceptions were associated with the HIV/AIDS transmission. The most common of them was the only what the men who have illicit and sexual relationships would get the HIV/AIDS. The other myths were related to urban population only people living in urban areas can get the infection. So, some of even believe that it is a traditional disease of commercial sex workers, and while others say that young people will get this disease so fast and quickly, so youth are the specially one where they are being affected. Research finding shows that the HIV/AIDS was very low among the tribal communities compared to the national figures due to the isolation, early marriages, and minimal access to the information. Indigenous people are isolated in India with the states of Andhra Pradesh, Arunachal Pradesh, Assam, Bihar, Chhattisgarh, Goa, Gujarat, Himachal Pradesh, Jharkhand, Karnataka, Kerala, Madhya Pradesh, Maharashtra, Manipur, Meghalaya, Mizoram, Nagaland, Orissa, Sikkim, Rajasthan, Tamil Nadu, Telangana, Uttarakhand, Tripura, Uttar Pradesh, and West Bengal in 26 states and union territories. Over 104 million tribal people and across 705 indigenous communities, the count of 8.6% of the country's population live in India. The Constitution of India recognizes the special status of indigenous people and the scheduled tribes and provides a safeguard to protect the rights and culture. However, despite the large number of tribal people have remained, the managerial and geographically, the socio-economically, politically, and therefore in the national faith for the mainstream population. The indigenous population who live the same where in the forest or hilly areas or who sometimes appear in the news because their children are malnourished. Though it has long been suspected that tribal people have poor health and unmet, the tribal people have some health problems similar needs, especially communicable communicable diseases including HIV/AIDS, TB, and COVID-19. Awareness among the women tribes was lower compared than men tribes. Lack of awareness and permissive of tribal societies and tribal man migration to the big cities in search of employment and awareness regarding shaving in barber. There is no awareness regarding that to them, and shops, etc., material, sexual relationships, tourism, displacements, and these communities and HIV/AIDS and STDs, malaria, viral fevers, transmitted diseases. So, recent estimates of maternal mortality among the tribal women are available, and early marriages, early childbirths, the high percentage of anemia, and cost of institutional delivery due to the distance and lack of transport to continue the deterrents. So, considered to be at a high risk, the getting infected due to their risk-taking attitude, which exposes them to more visibility and vulnerability of any other sections of the populations. Recommendations for the prevention methods. The government has already implemented a range of awareness raising activities. The national and local must be beyond a workplace program focused on HIV/AIDS to cover the preventions and the infections in community and such that requires a more wide-ranging approach of risk management for this. But there is a gap in indigenous living places systems approach in the management of prevention, community response, and the treatment of initiatives. The Government of India, state government, integrated tribal development societies, and NGOs also doing good welfare programs for the welfare indigenous people in India. But due to the shortage of funds and it was not so satisfactory, present needs were more welfare activities to the survival and tribal families in India. Hence, there is a need of HIV, AIDS, and TB and COVID-19 awareness to the tribes in their local languages and through their tribal leaders and headmen and traditional medical practitioners and tribal leaders who live within the HIV and AIDS. Need to make a documentary with the local indigenous languages and need to conduct awareness programs and fill-ins and shows regarding the prevention of all these things and villages and schools. They have to put up on the shows and need to maintain the health records for each indigenous person with the health problems and statistics and keep them in the nearest offices. Need promoting a standardizing tool for monitoring progress in HIV prevention among indigenous people in India. Need to provide more poverty reduction programs for poor indigenous families. Need to establish a special indigenous hospitals to provide more service for HIV, AIDS, and TB and COVID-19 prevention and care facilities in the tribal villages that live in forest remote areas. Need to provide free grants for poor indigenous people who are affected by TB and HIV, AIDS, and COVID-19, etc. There is one need medical ambulance for each indigenous villages of 10 indigenous villages for emergency medical support for poor indigenous people. Need to provide 100% employment for the indigenous people in India to eradicate the poverty and save the endangered situation for the indigenous people. Need to sanction 100% land titles as per the Government of India. Forest Rights Act in India and need to distribute FRA land titles to eligible tribal beneficiaries to survive and save from poverty to prevent from HIV AIDS. We need to do, we want to do more activities for HIV AIDS welfare activities through our Integrated Tribal Development Society, ITDS NGO, and we need to establish the international funding for indigenous people, health programs and problems. We have requesting and looking for your support and do more non-profit services for indigenous people in India. Thank you. Akila Rajeshri Gangu, Indigenous Leader, IGWA Network, Coordinator, Integrated Tribal Development Society, ITDS, Polavaram Village and Mandal, West Godavari District, Andhra Pradesh, India. Mail ID indigeoustree@gmail.com. Thank you.
Thank you.
Hi, greetings everybody. My name is Akila Raj.
Thank you, Akila. We will now move on to our next presentation, which is by Pandi Ramesh Babu. And the presentation is coming from India as well. Mr. Pandi Ramesh Babu went to high school in India at an Indigenous hostel, living with Indigenous children, and then studied social work, hoping to eventually work with government. Ramesh struggled financially while working on his Master of Social Work degree, but continued to follow the work of Tribal Welfare Department to keep track of the new developments. After continuing his studies with support from the German Social Service Society, Ramesh worked in service of low-income communities for 2 years. Ramesh Babu worked for different NGOs and implemented Indigenous development projects such as International Fund for Agriculture Development, Tribal Women's Development Projects, and worked in Tribal Livelihoods Development Project. Ramesh Babu is currently working on his PhD to do more studying Indigenous peoples' issues and development programs in India, and is engaged with one particular experiment in an Indigenous village pertaining to improvement of livelihoods among forest-based Indigenous people, migration laborers, and the prevention of tuberculosis, HIV/AIDS, and COVID-19. Ramesh is a founder of the Mahatma Gandhi Indigenous Peoples Social Entrepreneurship Center.
Hi, greetings everybody. My name is Pandi Ramesh Babu, PhD scholar, Department of Social Work in Nagarjuna University, and also doing social work among Indigenous people. I studied social work in undergraduation and studied Master of Social Work and lately joined in PhD in social work. I belong to scheduled caste, which is equal as indigenous community in India. When I worked with Chensu indigenous community in Alamala Forest in Srisal area, I have experienced that struggles that poor indigenous faced on a daily basis, whether food or education or health. And I have experience at ITDA, Integrated Travel Development Agency, PTG Chensu, prepared me do my own way of service to indigenous community. Government of India, State Tribal Welfare Departments, and ITDS, and like NGOs, inspired me, and they did great work for poor indigenous people through educational institutions, mobile hospitals, and developmental programs. Hence, I was inspired by them and wanted volunteering was the best way to serve poor indigenous communities. I have 15 years experience in indigenous development programs in India and having work experience more than 23 indigenous communities in India. My presentation case study on tribals and HIV AIDS in India. India has the second largest concentration of tribal population in the world. Indian tribes constitutes around 8.2% of nation's total population, constituting nearly 8.3 million according to census 2001. There are 705 tribes in India, located in five major tribal belts across the country. There are in all 35 states and union territories in India. Indigeneity concept is central to discussions of political and legal rights of indigenous people. It is argued that there are enough evidences which demonstrate that India's tribal people are the indigenous people of India who are forced to remain marginalized. Despite India's defense in global forums, India's apex Supreme Court has recognized in a 2011 verdict scheduled tribes as the indigenous people of India. Among 75 indigenous groups have been categorized by Ministry of Home Affairs as particularly vulnerable tribal groups, PVTGs reside in 18 states and UT of Andaman Nicobar Israels. The Ministry of Tribal Affairs, Government of India, and Ministries of State Tribal Welfare and ITDA and Ministry of Health and Family Welfare, Government of India, State Health Departments are doing good and dedicated services for indigenous people, but need more services and more budget for indigenous people development programs. Scheme of development of particularly vulnerable tribal groups, PVTG, is exclusive for them. Even now, indigenous people are to be facing the problem of eviction from their natural habitat, non-conferment of ownership rights over the natural resources, least participation in development programs, poverty and indebtedness, food insecurity, high rate of morbidity and mortality is as revealed from the existing literature and government reports. Nomadic tribes in India. There are 1,500 nomadic tribes communities and around 150 notified tribes communities in India. Traditionally, the tribes were under and therefore could not integrate into Indian society. These tribes also don't have livelihoods. The tribal population in the country has poor health generally due to, among other factors, their poverty and social vulnerability. Tribal people are known to have sexual practices that differ from those of mainstream cultures, and a high prevalence of sexual transmitted infections. Less or nothing is known about the prevalence of STI, HIV, and AIDS among tribal people in India, except perhaps in some of the tribal states of northeast of India, as these have high prevalence of drug use. The tribal population in the country is high, and their sheer number makes it imperative for the government to bring them in the fold of the national program. To be able to do so, it is essential to understand the behaviors, practices that drive the vulnerability and risk among the tribal people. This would help guide evidence-based designs of HIV/AIDS prevention, diagnosis, treatment, and care programs oriented towards tribal population. As per 2004 estimates, 4.2 crore people living with HIV/AIDS in the world, but there is no data, particularly for indigenous people who are affected by HIV/AIDS. In the olden days, the tribes lived in remote forests and collecting roots and fruits and hunting animals for food. Indigenous people, if fever comes, they are do fasting without food and stay in the sunshade. And if any sick, they take only forest trees leaves, bark, with mixing hot water only. More indigenous people died in indigenous forest villages. Immediately they will be leave that place and resettled in another place to live. Indigenous people cannot live without the forest. It is true. After socialization and through some changes in government legislations, Wildlife Protection Act, Indian Forest Act, etc. are implemented by government very strictly. Due to these acts, indigenous people are lose their rights and forest-based livelihoods and family incomes which are coming from their forefathers. Then they wanted to adopt new livelihoods like agriculture, small business, migration to labor works, etc. Then HIV/AIDS and indigenous people topic is here. Main reasons HIV/AIDS among tribals only. Poverty is the main cause HIV/AIDS in tribals, and mostly poor indigenous people whose monthly incomes are below 1,000 to 3,000 Indian rupees are in HIV/AIDS and risk. Mostly indigenous people who go to migration to urban areas for livelihoods are in HIV/AIDS risk. Mostly indigenous people who go to business to urban areas are in HIV/AIDS risk. Mostly who doing sex workers with unprotection sex also in risk. Though using used needles for injections also in risk. Due to they lose forest livelihoods, they started to go migration to urban areas for livelihoods. And non-indigenous people who entered into the indigenous villages for business, service, project constructions, etc. Though these people, few of indigenous peoples infected by TB, HIV, AIDS, virus, fevers, corona, etc. Some indigenous peoples have migrated and become nomadic tribes due to lack of permanent settlements. They have no identity cards and no support from government. Hence, the government schemes not go to them because this lack of identity. After so many years, government of India recognized that indigenous peoples cannot live without the forest. Hence, in 2006 year, Government of India given special rights to indigenous people with the Forest Rights Act. This is one of the valuable gift for indigenous people which is given by Government of India. Through this, lakhs of indigenous people are getting land titles on their previous lost land. FRA Act is life for indigenous people in India. Government of India given the act and the rights to indigenous people, but the local government officers doing some negligence due to lack of staff and lack of particular records and to do some boundaries. Special attention under for tribal population in India, the National AIDS Control Program, NACP, in its third phase plans to go beyond the high-risk behavior groups covered by targeted interventions. This entails extension of interventions to populations that are vulnerable to HIV, such as the tribal people and socially disadvantaged sections of the population in both rural and urban and tribal areas also. This necessitated undertaking a rural risk vulnerability assessment and social assessment of HIV/AIDS among tribal people. The social assessment among tribal people documented the prevalence and risk of HIV/AIDS among tribal people, their levels of knowledge, social and behavioral causes and consequences of HIV/AIDS, including stigma, and strategies used for prevention, diagnosis, treatment, and care (PDTC) of HIV/AIDS in order to ensure appropriate program design and implementation to reduce the spread of HIV/AIDS and improve its management. Primary data collection, review of existing literature and programs, consultation with stakeholders, and development of tribal action plan was an integral part of assessment. The primary data collection, qualitative in nature, was done among the tribal populations in 6 states of the country, namely Andhra Pradesh, Chhattisgarh, Rajasthan, Maharashtra, Manipur, and West Bengal. The National AIDS Control Society and Andhra Pradesh AIDS Control Society is doing dedicated services in India and in the states to prevention of HIV/AIDS among tribals and non-tribals in India. My recommendations need to provide cultivation lands through FRA Act titles for all eligible indigenous families to eradication of poverty and to save from HIV/AIDS risk. There is need to support free grants for HIV/AIDS indigenous, infected and affected indigenous people for survival. Need to provide free house sites and house constructions for infected and affected indigenous people for survival. Need to provide small financial support to self-employment for infected and affected indigenous people for survival of their families. Indigenous HIV/AIDS awareness clubs to be formed in the indigenous communities and need to do aware to all indigenous villages every week. Most of the indigenous peoples, illiterates, they don't have awareness about their health. Hence, need to provide HIV/AIDS prevention awareness in their indigenous languages and through TV channels, small film documents. There is no separate HIV/AIDS prevention program for indigenous people in India. Hence, need to be implement separate HIV/AIDS prevention programs for indigenous people in India. The indigenous families are different stages of socio-economic development with different problems and aspirations which demand community-wise survey. So, plain area indigenous people, primitive indigenous people, and nomadic indigenous people have their problems and the ways to solve these problems. Few of nomadic tribes have no identity and caste certificates, hence they are not getting any benefits from government welfare schemes and need tribal community-wise identification of problem and to be solved. There is need to establish forest-based, non-timber, forest-based products industries by government in indigenous areas and need to provide 100% employment for Indigenous people. There is need to conduct continuously research on Indigenous families' economic health and save from pandemic diseases like HIV, AIDS, Corona, and TB, etc. to prevent endangered population. There is need to establish international Indigenous universities in every Indigenous countries and need to teach Indigenous culture, Indigenous crops, Indigenous professions, Indigenous traditional health practices, Indigenous languages, Indigenous arts to save and prevent from endangered populations. Thank you everyone to patiently participation in this presentation. Thank you.
Thank you so much, Ramesh Babu. At this time, we will be sharing the screen with photos from the Indigenous people, the forest-based Indigenous peoples in India. The photos are provided by Ramesh Babu, and we will just view them so that we can get a sense of the communities that he is working in.
Hi, everyone. So Ramesh Babu has shared these with us. So here is he's provided the context now for the pictures and photos that you're about to see. And he's also included his contact information here. If you would like to speak with him or ask any questions, he can be reached at the email address below. Due to the COVID-19 situation in India, the country is in lockdown and it's very difficult to record or get internet access. And so he was unable to do the slides at the same time as the presentation that he recorded. And so we've agreed to share these on his behalf. So here are some photos of the forest-based Indigenous peoples constructing their houses with materials from the forest in India that he spoke about. And again, the forest-based Indigenous women who collect hill grass and make sweeping brooms with these materials. And here are Indigenous women and men collecting and processing tamarind as part of their livelihood. And some photos of children playing in the forest. And the steps in collecting honey, Indigenous men collecting honey for their livelihoods. And as well, another thing, collecting bark, tree bark from the forest. And some photos of cultural practices and worshiping traditional gods and goddesses in India. And some dancing at traditional gatherings, again, another expression of culture. The beautiful, colorful dresses and clothing. And this is some of the traditional medicine that was spoken about, used in India, and some of the information that was collected by Ramesh Babu. And here is the Forest Rights Act of 2006, which was a land titles process in India. And that is all he had to share. Again, if you would like to get in touch with Ramesh Babu, you can reach him at the email address there.
Thank you, Janessa. Our next presentation, the CAAN's Roadmap to Policy and Communications Leadership, Part 1, is going to be presented by Marguerite Kisika Paisis. And again, I apologize for any mispronunciations. She is coming from us from the Canadian Aboriginal AIDS Network. Marguerite Kisika Paisis is a First Nations Cree woman of the Moose Clan and Bear Clan with family ties to George Gordon First Nation and Pepikis First Nation in Treaty 4 territory of what is now known as Saskatchewan. Daughter to the matriarch of the Kisika Paisis family, mother of 2 beautiful adults, and kokum to 3 amazing grandchildren. Standing strong in her indigeneity, she gives gratitude to the Creator for the opportunity to walk alongside the many teachers and healers, taking with her the many lessons and blessings on her journey. She is humbled by Kisimanito, Creator, and her ancestors as a traditional medicine practitioner. She maintains a relationship of knowing and protecting the plant world. At the end of her journey, she will lay her bundle down as a baby-catching ceremonial woman, leaving footprints for those to come. In the colonized world, she leads as the CEO of the Canadian Aboriginal AIDS Network and celebrates 30-plus years of responding to HIV, HCV, and colonial impacts in Saskatchewan's Indigenous communities through culture, ceremony, humor, and Indigenous ways. So with that, we turn the presentation over to Marguerite's video recorded presentation.
Tansei, today I bring greetings from the Canadian Aboriginal AIDS Network, virtually welcoming the many Indigenous people and allies from around the world to Turtle Island, the land of many distinct Indigenous nations along with their ancestors. The Canadian Aboriginal AIDS Network is a nonprofit coalition of individuals and organizations which provide leadership, support, and advocacy for Indigenous people living with HIV and AIDS, regardless of where they reside. The national network is committed to addressing the issues of HIV within the Indigenous context. Although the beliefs of Indigenous people vary widely from territory to territory and from person to person, the network has made a commitment to conduct its activities in a spirit of Indigenous wholeness and healing. This commitment can only be overcome by respecting our differences and accentuating our unity of spirit and strength. And I want to say that I would support all of the Indigenous people that come from different lands to share some of their solutions from their culture and their traditions and their ceremonies to be able to bring life to the people. That's where we are as Indigenous people. We're very closely connected to the Creator. And that's why when the settlers and the colonizers came in and they did what they did on these lands, they weren't able to break our spirit because our spirit is very strong and that we're very spiritual. And so today we still remember who we are as Indigenous people of this land now called Canada. And we still carry our customs, our traditions, our ceremonies, our language. We still remember who we are. We know who our ancestors are. We're very connected. And so that's what I see as a way forward when we're looking for solutions, is we have to ask we have to look at where we came from and know where we are to know where we're going. And so those are important ways of understanding from an Indigenous perspective, and that as we move forward, that we will have solutions for what people need here on this land, and not only Indigenous people, but all nations. We are really looking for solutions for what we're faced here today on this land, and we have those solutions.
Thank you for that. The next portion, part 2, is going to be presented by T. O'Donnell, also from the Canadian Aboriginal AIDS Network. Teachma Quinn Atnas T is from the Claoquot Na'at and Ahosat First Nations, 2 of 14 groups that make up the Nuchanuth Nation on the west coast of Vancouver Island, BC. She is from the Seacher, Louis, and Marshall families. She is a mother of 2 grown children and the grandmother of 7. She is married and resides with her husband in her ancestral territory. T embraces her Nuchanuth world view of Hishukish Sawak. Everything is connected, everything is one. And Isak, respect for a self or for others. It is the basis of her approach to life, as well as to her role as the Director of National Programs with the Canadian Aboriginal AIDS Network. She views her role as one of stewardship, where the duties and responsibilities are entrusted into her care temporarily, and that great care must be taken to ensure it is passed on to the generation to come. T has a rich academic background. She has obtained a degree in law from the University of British Columbia, a Master's of Science in Psychology, and a BA in Business Administration, Psychology, and First Nations Studies. T has worked in Indigenous health management for the entirety of her career that has spanned 20 years and is the current CAAN Director of National Programs. And with that, we turn that over to her video.
Waiklashnas, Hayin Tiechma, Nahamaklashachim Yesaksabian Hatwia, Waiklashnas,
Uklashish, Tiechma Quinathnas, He Stakish Ahazit At. My English name is T. O'Donnell. I am of the Nuchanuth people from the Ahazit First Nations on what is known today as the west coast of Vancouver Island, British Columbia. I am also the Director of National Programs with the Canadian Aboriginal AIDS Network. Before I begin, I would like to recognize the Indigenous territory that we are on today. And I would like to say kleko to all of our ancestors and the future generations.
There are 4 pillars to our national programs that create a framework. The first pillar is knowledge transfer. This reflects the development and delivery of prevention education, resources, and training. The second pillar is resilience, the promotion of Indigenous health and wellness, and the recognition of our individual Indigenous rights and responsibilities. The third pillar is relationships, the allegiances created with Indigenous communities, aid service organizations, and other national partners. The final and fourth pillar is leadership, reflected by advocacy in action and timely responses to issues that impact Indigenous people wherever they may reside. The Canadian Aboriginal AIDS Network program team creates opportunities for Indigenous dialogue. We empower Indigenous voices, and we advocate for culturally appropriate, relevant, and collaborative inclusion in the decision-making and policy setting that so greatly impacts our communities, families, and selves. Indigenous societies have found a way to survive in the face of diversity because of knowledge transfer, resilience, their relationship, and their leadership as stewards of this time and this place. Since the creation of time to this present day, the cornerstone to Indigenous societies are their respective protocols and traditions. Indigenous laws evolved thousands and thousands of years ago and are based on our concepts of spirituality, how we see the world, how we see ourselves in it, and how we conduct ourselves. The Neutralist worldview is he shook a sawak, everything is one. We are all one. This oneness of all things, people and beings, one interlocking with the other, trails back to the time of our first ancestors and guides us forward into the future where our children's children's children will one day lead the way. There is a place within our organization for Indigenous protocols and traditions, and that is through policy. Policy that is grounded in Indigenous ways of life become more than a set of rules and guidelines. They reflect our self-determination as Indigenous people to be stewards over our own lives and the world we live in. In doing so, our Indigenous laws and governance to operate creates a sphere of authority that will have a long and lasting impact, not only now, but in the generations to come. The CAAN program team consists of several Indigenous perspectives. We are Mi'kmaq, Cree, Algonquin, Mohawk, Métis, Nklapama, Uchamath. Our Indigenous community and members are the core of the work. Through their participation in steering committees and councils, they advise and direct the work we do. This engagement brings the voice of Indigenous people to the decision-making process. Zoe Verlan, our Youth Leadership Coordinator, and Monique Fong Hao, the Women's Leadership Coordinator, both provide opportunities for our young people and our life givers to express their concerns and thoughts, celebrate their successes, and contribute to creating a future where Indigenous lives matter. Dylan Richards, the Community Readiness Coordinator, and Sarah Wakisu, the Promising Practices Coordinator, work with Indigenous communities to ground the prevention, education, and promotion of Indigenous health and well-being in ways that are culturally appropriate and relevant, as is evident in the resources, tools, and information documents that are created. Indigenous communities may make informed decisions with regards to the delivery of their health and wellness services. Trevor Stratton, the coordinator of the International Indigenous Working Group on HIV/AIDS, provides an international scope to the work we collectively do and creates opportunities for international conversations on the matters of health and wellness that are strikingly similar amongst the Indigenous people of this world. Jasmine Cottam, the Indigenous person living with HIV/AIDS liaison, keeps our team impactful in the most meaningful way, providing the living experience of herself and others so that our engagement achieves the outcomes not that we set as a team or that are set by our funding partners, but by the Indigenous individuals, their families, and the communities we purport to serve. There is a magnitude of behind-the-scenes coordination that needs to occur to ensure that the CAAN program team is effective, efficient, and accountable and transparent. In that regards, Janessa Tom is our administrative assistant, and she provides technical support that is needed to make our meetings, events, and gatherings a success. No program exists in isolation. While we work independently and we are spread across the country, increased effort has been made to ensure that as a team, we are working collaboratively. Each program and team member is like a strand of cedar, each strand bearing its own gifts. A cedar rope is strengthened when each strand comes together. It is braided and tightened. It is soaked in water and dried in the sun. And after much work, the cedar rope has the strength to pull up a massive cedar pillar. The pillars are raised until there are 4, and that is the structure of our longhouse. 4 pillars and strands of cedar intricately woven, creating purpose and meaning, providing a place to gather, to feast, to share, and to plan for the future. Most recently, with the support of VIVE Canada, the program team has been able to bridge work with the CAAN research team. Over the next few months, CAAN programs and research teams will interlock, bringing evidence-based Indigenous research to the hands of Indigenous people everywhere. In doing so, the self-determination of Indigenous people claim their respective inherent rights and responsibilities for their communities now and in the future, and the path we set on has space for everyone. Indigenous protocol, traditions, and customs have much to add to the HIV/AIDS pandemic. Through solid policy directives at the federal, provincial, and regional levels, Indigenous lives may truly be impacted in the most positive of ways. The 90-90-90 targets that were optimistically predicted for 2020 are still a long ways away from being a reality. And unless something shifts, those targets will always be just on our horizon. We must learn from our past, the trials and tribulations experienced, and forge our path in order to achieve the outcomes that we want, not just for ourselves, but for one another, not just for Indigenous people, but for all. In Nuu-chah-nulth, we would call this Iasak, which means respect. Do you hear the voices of Indigenous people? Do you learn from their protocols and their way of living in this world? Do you value their knowledge, their resilience, their relationships, and their leadership? Do Indigenous people have an equal and equitable seat at the policy and decision makers' table? Do we devise our own visions for health and wellness, or are we simply applicants for government short-term funding that cannot sustain our future? The Canadian Aboriginal AIDS Network is moving forward, embracing our inherent right as Indigenous people to create a future for our children, where HIV/AIDS, Hep C, TB, and STBBIs are no longer a stigma on their community, their family, or on self. CAAN is poised to bring the voice of Indigenous people to the forefront, to recognize and celebrate what it means to be Indigenous.
Thank you. Our next presentation is part 3, presented by Celine Aubin, who will talk about fostering the CAAN-VIVE partnership through a sprint, a collective decision-making process with specific outcomes related to CAAN's strategic communications plan. She will demonstrate how industry community alliances can augment HIV activism in Canada, and how both CAAN and VIVE mobilize their shared goals of supporting Indigenous PHAs to leave no person living with HIV behind. Celine Aubin currently holds the position of Manager, Partnerships and External Affairs at VIVE Healthcare Canada, where she supports clinical community partnerships to improve access to care and treatment for people living with HIV in Canada. Within this capacity, she will be talking about fostering the CAAN-VIVE partnership. And with that, we bring us the video from Celine. Thank you.
Good morning, everyone. My name is Céline Aubin, and I'm working for a pharmaceutical company called VIVE Healthcare. We also say just VIVE. VIVE is a very special and unique company because it's 100% dedicated to HIV. That means that we are working on research and development for drugs to treat and to prevent HIV. We've also worked in partnership with the HIV community to promote innovative research and to foster community-based programs. Clearly, having HIV drugs is a part of the solution, but HIV cannot be ended without a broader approach to health and without partnering with the whole HIV community. So all what we do it with the patient in the front head, and each population group is facing different issues regarding health, HIV, access to care, access to treatment, and each group owns the solution for their own community. This is what brings me in today, actually, and I feel very fortunate working with CAAN, as we are driven by the same purpose, to leave no person behind. So our journey together started a year ago with just a simple discussion where CAAN was sharing all the good work and the research that they are doing with Indigenous community around HIV. But they also share their lack of time and experience around translating their research into program planning and policy decision. This is where VIV came into play, and we proposed to CAAN to organize and to facilitate what we call a sprint meeting. So a sprint meeting is a kind of workshop with a specific methodologies to solve one question. And in the case of the partnership with CAAN, the question was, how can CAAN be recognized as the key influencer and stakeholder when HIV and Indigenous health are discussed in Canada? So basically, it was really like, how CAAN be the go-to person in Canada when anyone is talking about Indigenous health and HIV. Here, don't get me wrong, CAAN is already a key player and super strong already, especially with the community groups, but they're ready now to go to the next level. So what we've done is that we spent 2 very intensive days together, and on day 1, we work on the vision. So we took a step back and we first work on the long-term goal for CAAN. So where they see themselves in 2 years, in 5 years, who are the key stakeholders and influencers, and not only at community level, but also like to think about the political level, who's making the decision, who's giving the money as well. And third thing, what are the key messages that CAAN wants the stakeholders to hear regarding Indigenous health, access to HIV, access to care, access to HIV care, access to treatment. So this first day is like a huge brainstorm when you go super broad, like you try to explore as many ideas as possible, you try to think out of the box, and then with the voting systems, you narrow down all the key elements that you need to work on and that you need to bring to the next session. And so that was like super good and super intensive. So that was for day 1, and for day 2, we worked really like on very specific tactics to enable the vision. So at the end of those 2 days, CAAN ended up with a very simple but very powerful plan. The first avenue was to have a strong speaker training for CAAN's representative, together with a strong advocacy roadmap for the year, including meeting politicians, influencers, parliamentarians, and even media, and be very present in the Canadian conferences. The goal is for CAAN to be recognized by any stakeholders like political leaders, public health units, advocates, and non-profit organizations, journalists, and researchers, and they have to be seen as a trusted resource for guidance, comment, information when it comes to Indigenous health. I am in Canada since 3 years, and coming from France, as you can hear, and indigenous health was a complete new issue for me. And I really realized that even if I can understand the need, I will never be able to have the right cultural approach to it. And clearly CAAN is the right player. I'm not a policymaker or a politician, or I'm not even like a key player in any space. But this partnership really changed my perception on how to work for and with Indigenous population. And I really hope that it will also change the perception of key policy players as well. So definitely the best way to move forward and to achieve our common goal, to leave no person behind and to leave no Indigenous person behind, is to support the work CAAN is doing and to help them to raise their voice strong and loud in Canada and to become a policy and a communication leader in Canada. And that's pretty it for now. Thank you so much for listening to me, and I would be very happy to answer any questions at the end of this session if needed. Thank you.
Thank you, Celine. Our next presentation comes from Marnie Amaro. Marnie will share about best practices in Indigenous-led HIV communications, outreach, and policy from the perspective of the AHA Center, a community-based collaborative research center housed at CAAN. Marnie Amaro is of Acadian and English-Irish descent. She has her Master of Arts in Cultural Visual Anthropology from the University of Alberta, where her research focus was on Aboriginal media making. Marnie has worked with and lived in several First Nations, Inuit, and Métis communities in Canada since 2001 and has been involved in the field of Aboriginal sexual health since 2009. She currently holds the position of Community-Based Research Manager with the Aboriginal HIV and AIDS Community-Based Research Collaborative Center, AHA Center, a project of the Canadian Aboriginal AIDS Network. In this role, she works collaboratively with academic and community researchers and organizations to build and maintain relationships, offers support in all stages of Aboriginal HIV and AIDS community-based research, and to promote research. She is co-editor for the Canadian Journal of Aboriginal Community-Based HIV/AIDS Research, co-chair of the National Aboriginal Research Advisory Committee with CAAN, a member of the AIRN Blended Leadership Community, and a team member on several research grants.
Hi, everyone. My name is Marnie Amaro. I'm a community-based research manager with the AHA Center, a project of the Canadian Aboriginal AIDS Network. I'm really excited to be here at the 8th International Indigenous Pre-Conference on HIV and AIDS. I've really been fortunate in the past where I've been able to attend these events in person, but we all know that that can't happen this year. And it's very different. So I hope that you're able to find ways to take advantage of all of the amazing knowledge and information that's being shared, and that you're enjoying the process as well. So before we begin, I thought that I would share a little bit about myself. I'm calling in from unceded Mi'kmaq territory in Dartmouth, Nova Scotia. I grew up in a small fishing community in Nova Scotia, but I live now in one of the urban centers. On my mom's side, I'm English-Irish descent, and on my dad's, French Acadian. I come to the work that I do at CAAN through the lens of anthropology. That's what I studied in university. So I would like to hope that I bring a unique lens to the work that I do at CAAN. Just a little bit about the AHA Center before we talk about our journey, the AHA Center's journey with VIVE in this training environment. So the AHA Center is it's a national community-based research collaborative center. And what that really means is we give support to the research work that is being, the community-based research work, I should say, that is being done in First Nations, Inuit, and Métis communities across Canada. We are a small but mighty staff of 2.5. So I have the great fortune of working alongside Sherry Puyak. The two of us have full-time positions, and Jennifer, our communications assistant, is working with us on a half-time basis. But we're able to put out a lot of work with the support of our community, our research team, and our elders as well. So if you take a look at our little list here, this will give you an idea of some of the kinds of projects and information that we share with our community. Everything, I think, can be housed under the header of research and knowledge translation support. Everything that we do at the center is basically for that purpose. We have a peer-reviewed journal that we put out once a year. It's a really great resource, and I think it tells the story of Indigenous HIV research in Canada. So check that out if you have a chance. We give funding support to teams that are interested in developing projects or grant proposals that are going in to larger research bodies. Every 2 years we have our WISE Practices gathering, which brings together researchers and community members from across Canada to share and learn about all of the amazing work that's going on in the country. We give indirect and direct support to students, to Indigenous people living with HIV, and even our academic colleagues in some instances who are interested in learning about community-based research, who are interested in learning how to work well with Indigenous communities. There's a lot of reciprocal learning, I guess you could say, that happens in these instances and throughout all of the work that we do. So if you're interested in learning more about the AHA Center, you can check us out on the website, ahacenter.ca. And we also have a fairly active Facebook and Twitter and Instagram accounts as well, where you can come and have a conversation with us if you would like. So what I'm really here to share about today is the journey that we've been on with VIVE and Impact. It occurred to me today that it was a year ago that we first met with VIVE to talk about this training and what it might look like and the kinds of support and tools that we could gain from this partnership. I remember walking out of that meeting thinking, holy cow, this is the puzzle piece that we've been missing. CAAN has been really good and effective, I think, at sharing our research work with our community. So be they our academic colleagues or our Indigenous people living with HIV or students and so on. But one of the places that we've really needed to build our understanding and support in, I guess, is how to effectively engage policymakers and government people so that we can take this amazing work that we're doing in both of our research work and our programs work and turn it into or create positive change in our communities. So yeah, working with VIVE and Impact has been really good that way. I feel now that if I have someone who comes to me from a community-based organization saying, I really want to get the ear of this politician or this policy person, I I have an understanding of what I need to be able to share with them, and the tools and so on, and the processes involved in doing that in a good and effective way. I'm still learning, of course, and there's lots to learn, but I'm really excited that I'm able to better support that piece of the work that's so important at the AHA Center. They have, working with VIV and Impact has also helped us really to up our social media game, I think. We all, all the staff has Twitter, Instagram accounts, Facebook, and so on, but running your own personal accounts and running an organizational account are two very different things. So there's all kinds of tips and tricks that we've learned from working with VIV and Impact through the training that we've done, that I think is really what we're already starting to see is helping us to up our social media game. And I think eventually, when this work is all wrapped up and done, we are going to be able to do just that. So that's a very exciting prospect, I think, for the AHA Center staff to be able to take this information that we're learning from VIV and Impact to make it relatable and usable for the Indigenous communities that we work with across the country, and to be able to share this information not only with our staff as well, because we're going to be doing staff training. So it's been a very big learning curve, but very exciting. And I can't say enough about how amazing the VIV and Impact staff have been. They listen deeply to us. They really walk alongside of us and let CAAN take the lead, because they understand that, the people, we've been doing this work for a long time with our communities, and we understand what's needed. So in closing, I'd just like to say thank you to everyone, and especially our colleagues at Impact and VIV, and thank you for listening. I hope you have a great day.
Thank you, Marnie. Our last presentation comes from Renee Mashing, also from CAAN. Renee will conclude the panel presentation with a review of a short guidance document related to their lessons learned so far, with the goal of sharing best practices, communications tools, and to promote national and international partnerships. Renee Mashing is a First Nations woman originally from Southern Ontario, who has dedicated her professional energies to working with Aboriginal peoples in health-related programs. She has worked in addictions programs, in community health education, and for more than 18 years, Renee has been honored to contribute to the Aboriginal HIV and AIDS movement in Canada with dedication and determination. Renee was the executive director of Healing Our Nations, the Atlantic First Nations AIDS Network, from 1997 to 2005, and then began employment with the Canadian Aboriginal AIDS Network as a community-based research facilitator, supporting a community response to HIV and AIDS through research. Presently, Renee is the Director of Research and Policy with CAAN and Principal Knowledge User or Knowledge User on several active research projects. Renee lives with her husband, sons, and menagerie of pets by the ocean in Micmac territory, Nova Scotia. And with that, we turn that over to the video.
Good morning, good afternoon, good evening, wherever you are as you're watching this video. It's wonderful to have the opportunity to contribute to IPCHA, and specifically this session. It's also an honor to co-present with my esteemed panel members and session moderator. This presentation focuses on how we are moving our work forward in the context of the partnership that you've been hearing about. My name is Renee Mashing. My bloodlines are from Six Nations of the Grand River in Southern Ontario, Canada, in the middle of the country. I'm also Irish descent. I work as the Director of Research with the Canadian Aboriginal AIDS Network, or as you've heard, CAAN. Now, to begin in a good way, I'd like to acknowledge that my work is ongoing in the traditional territory of the Mi'kmaq Nation on the east coast of Canada. The pictures you see on this slide are the Atlantic Ocean and our East Coast office building, Saskatchewan, where CAAN's head office is located, our organizational logo, and my family. Now, to the Indigenous peoples of the San Francisco Bay Area, I respectfully express appreciation for the ceremony and plans that have already occurred to welcome visitors to your territory. Collectively, I'd encourage all of us to please consider where you are now and join me in acknowledging the responsibility to engage with the Indigenous peoples who has always called the land their home. In making this acknowledgement, we commit to walking in these territories with respect for the land and the people around us. I want to acknowledge the amazing team of colleagues that I work with and our network of members. Sharing a picture of my loved ones is an acknowledgement of how they support the work I am part of. And I encourage you to think about those who keep your home fire strong and support our global response to HIV/AIDS. So to begin this session, we considered an Indigenous lens on the process. As we began meeting with VIVE, we began to work with Impact. We talked about strategies for communications and recognized we wanted to tailor that messaging or be mindful of mainstream audiences and communities, Indigenous communities, and the incredible diversity within this umbrella term of Indigenous, and communities within communities, women, youth, Two-Spirit people, and so on. As we began doing our training, we realized that we were really being asked to walk in two worlds and talk with or communicate with two or more audiences. Now, this is the context of the work that we do generally in the Canadian Aboriginal AIDS Network. And so as we were listening to our training sessions, we were listening to the spirit of what was being taught to us and talked about and interpreting all the way through, well, we would do this differently with this part of our community or that part of our community. And I hope that we can offer the same to you as you're watching this video, that the spirit, the ideas, and the concepts will be meaningful, although you might have to reinterpret how you would actually fully implement in the context where you work and the lens with the communities and territories where you engage. So you've heard the presentations from my colleagues already describing the process that we've been part of. Just a little bit more background. As we began our meetings, we started off with just one or two of us and then grew to a group of 5 or 6, looking at the objectives that we refined, the process that we were going to undertake, and really the objectives or the goal that would come out of this process. Why would we be invested to work together? So we had 3 key points. We want to see CAAN, which is now over 20-year-old organization, viewed as a trusted resource of government officials and key decision makers. We want to have these groups view CAAN as a critical stakeholder in decisions regarding HIV and health-related matters, and really to drive home and incorporate the message of nothing about us without us. Indigenous people are leaders and have the solutions we need for our communities. Again, thinking of our audiences, we are the experts, so come to us, even though that may not always be a word that we would choose to use specifically. Having sorted out our objectives, we then wanted to narrow down our key messages, the clear and concise points that we want to communicate to the rest of the world or the rest of the country. So, as experts, as trusted resources, in the context of nothing about us without us, peer-led responses lead to stronger health outcomes. Indigenous peoples, particularly Indigenous peoples with living experience, are the absolute best resources for engaging with our community. HIV stigma generates more HIV. I think this is universally understood in the world. Stigma hurts us. We know this as Indigenous peoples, and we certainly know this in the context of HIV, and more generally in the context of STDBI, or sexually transmitted bloodborne infections. And we need a response to the HIV crisis growing in Canada, especially in Indigenous communities, where we continue to see unacceptably high rates of HIV transmission. So we've got our objectives, we've had our key messages, and then we had to decide what activities we would be undertaking to learn more about moving all of this forward. And so we came to a 3-pronged holistic approach to achieve our goals. We have selected and are in the process of grooming, training, working with spokespeople And we've done a series of training sessions collectively and are now moving into individual sessions. We want to produce a bigger than ever before Aboriginal AIDS Awareness Week for December 1 to 5, 2020. Historically in Canada, we've used the terminology of Aboriginal. This will probably transition to an Indigenous label going forward. And of course, we had this meeting and planned these steps in January of 2020 before we imagined that we wouldn't be coming together in person. So bigger than ever and more unique than ever, because it will need to be largely virtual sessions. And we wanted to engage as a third approach with relevant politicians. Again, understanding that politicians would mean parliamentarians in a mainstream context, as well as our Indigenous leadership. So, with all of this planning in mind, we are moving forward. And what I want to share with you in this presentation are some of the wise practices or lessons that we're learning, how-tos to achieve our next steps. So this is a bit of a presentation of the work to come. So, first thing that we were reminded of, be prepared. Learn about the audience. Always think about the purpose of the engagement. And so while you're drafting your speaking notes, while you're preparing for the session, why are you going? Why is the audience coming? And is there anything interesting that you can share? And I would kind of add to that, not only interesting, but useful, right? We really want to make a presentation that would share skills, even as we're in this early stage of learning ourselves. One of the interesting insights, I think, and aspects that helped us to have access to people with more expertise in terms of communication was learning about who has influence and where. So, of course, we identified that we wanted to work more closely with policymakers, with politicians, Indigenous and parliamentarians. And we also talked about media. Now, of course, media is an important resource, but really thinking about the power of media and recognizing how media is tracked by policymakers and politicians. That learning to frame policy issues for media uptake and it's an opportunity to reflect what's happening in community. But we really need to be thoughtful about how that gets packaged. And media are often interacting with politicians and policymakers as well. So if we get media on our side, not only is there a chance to promote messages or see publications, there's also an opportunity for our key messages to be woven into other work that media representatives might be doing. So in order to leverage and support the power of media, we were talking about how to pay attention to what media wants and needs, particularly being mindful of when the deadlines are in a workday, thinking about key headlines, providing quick sound bites or quotes, images, and always a contact person. So some insights about, as you start to think about reaching out to media, reaching out to influencers, how can you be most prepared to have them engage with you? So in that preparation, in that understanding of we'd like to work with this group or that group, or we see somebody in a position to really advance one of our concerns to help us to address stigma, we wanted to think about what materials we would present and to be mindful about being intentional and strategic, being thoughtful. If you only get one chance, who's the best chance or where is the best chance? Communicate key messages concisely and clearly. Always have an action, a call to action, and ask, we want you to work with us to do something. Of course, this is a very core Indigenous value, to build relationships, to connect with, and to understand that we're going to work over time, and it's an investment when we're talking about Indigenous health. And so as we meet with policymakers or politicians or media, as we work to be trusted and critical, and to understand that nothing can happen without us, that those relationships help us to solidify our objectives and key messages. Mind your brand, which of course in the context of nonprofit organizations and our small programs is a little bit of a corporate speak, but really be thoughtful about how you want to position where you work and who you work with. And don't overwhelm your audience. So hopefully I'm achieving that goal today too. So when we're framing a key message, for CAAN, or for myself as one of the CAAN representatives, we came into this process and into the sprint with all kinds of ideas, lots to talk about, lots of context, so much enthusiasm. And so Celine worked very hard with us to help us to think about how to narrow down to our 3 key messages: that we want to see peer leadership, that we want to see a response to HIV stigma, and that we must understand that HIV is still a crisis in Canada and the world, particularly for Indigenous peoples. And so we worked on key messages as the main points that we wanted our audience to hear and remember, recognizing that within that body of information, we could address all of the other issues. So we were looking for short statements that could be easily remembered. Often these would reflect the purpose of an organization, a specific issue, and why the issue is important. And when you learn your key messages, ideally, they help you to stay on track. And this was also thinking about in interviews, if we're being asked questions that might be a bit challenging, it's a way to loop back to the key message. And also because a number of us are going to be or have opportunities to find ourselves in places where we might be a spokesperson, that there would be a consistency of message so that our organization is saying the same thing about the same topics. Just some examples of some digital media tools or digital advocacy tools, just again to hopefully be concrete and useful in this presentation. Some of the areas that we'll be working on more are strategic emails, thinking about the ways that we can use software to help us with MailMerge and MailChimp. Of course, in this context of COVID-19, more than ever, we're working on video meetings and webinars and have an opportunity like today for panel events. You can see that we're actually using our tools. And of course, I think many of us are very familiar with newsletters and press releases. And then thinking about microsites as, again, a way that you can steer somebody, again, your policymaker, your politician, your media, to a particular source of information about your topic that is very specific. We have looked at engaging in person. We've looked at engaging through digital advocacy and digital outreach. We've also been talking about the power of social media and learning the 70-20-10 rule. And again, offering this in a context of what we're going to be working on. So hopefully you'll see this reflected in CAAN's work going forward, and it may be useful as you consider the way that you're doing your work. So social media posts with graphics are way more interesting, much more likely to get attention and to be retweeted. When we think about using social media, the majority of your time and energy goes into posts that have a call to action or some sort of way that directly asks the person reading the post to be engaged. 20%, so one day a week, one out of every 5 posts is resharing. And that's about relationship building again, those key contents that accounts and audiences are a two-way street. And it also shows that your account is active and current as you're resharing information. And then just a little bit of time spent around disseminating information that is really purely information, but might give context or detail to support a particular objective. And so interesting for us to reflect on how we are managing this already at CAAN. When we have these amazing opportunities, one of the things that we're also being encouraged to do is maximize our messaging. So if we're interviewed, if we have an opportunity to record a session, for example, get a copy and distribute that amongst your membership, distribute that to politicians and to other media, get it out there. And use that public content to influence the position, to the issues that we're talking to, and or to show our membership that you're actively supporting their needs. And this is a really important part about accountability, right? How do we make sure that the people who we work with, the community that we work with, know what we're doing as an organization, as individuals working within this organization, as colleagues in a national organization with staff from coast to coast? This is a way for us even to share internally and externally. So really thinking about understanding the promotion of our messaging as a promotion of the work of the organization and perhaps not self-promotion, which is a little bit of a barrier that I know I'm learning to address. Now, related to that notion, and I think also related to the notion of how we work across an Indigenous lens and a mainstream lens, and how we understand what it means to be present personally in social media or in the world and the work that we do. But we're really being encouraged to think about how to raise the profile of the spokespeople, particularly within CAAN, but really of the organization. And so again, that reminder that we could make sure that we, talk about an engagement, talk about an interview, share it on our personal accounts, and that builds up our reputation as a trusted and critical decision maker and influencer, and reinforces that nothing is happening without us. And some thoughts about our personal profiles, some guidance from our friends at Impact, that we want our profile to say something about us, to maybe present. I'm using Twitter to make sure that I get to share about the great work that I'm doing. Show your personality, think about the way that you write your bio, the profile picture you choose, and for something like Facebook, for example, where you have more than one opportunity, the cover photo. But also to remember that you are a reflection of the work that you represent, the project, the organization. And so one of the steps that we've taken at CAAN for some of our staff is to create personal profiles as well as more professional profiles. And so in our professional profile, to tag CAAN or a context that specifically speaks to the work that we're doing. And then that leaves us a little bit more space to, have our own personal sides that are part of what may pull us into the work, but maybe not what we want to share with all our colleagues. So, coming to the end of the presentation, please stay tuned. We're doing more training within CAAN as we're learning. We're developing train the trainer work. We're looking forward to sharing this presentation, and we're very excited to share more and more. Please watch as we learn to walk our talk. Watch for news about Aboriginal AIDS Awareness Week, how we rebrand it, and think about messaging and activities going on from December 1 to 5. There will be events, virtual, hopefully in person by that point. There'll be media stories. We're working on renewing our website and having more of a presence on social media as an organization and individually. Very, very exciting to welcome our communications manager, Nuria, who is coming into the organization just as we're doing all of this learning. So we have this wonderful opportunity to have some professional support and have some training. So hopefully we're not quite as hard for her to work with. That's the goal. So just to wrap up, we know that working with and for Indigenous peoples, peer-led responses lead to stronger health outcomes. When we work for our people, when we work with our people, when people with living experience are speaking out, there is power behind that presence. We know that HIV stigma generates more HIV. We know that stigma prevents people living with STBBIs to access services, to access care, and to be able to be given the treatment that they need. And we need a response to HIV, the crisis that is growing in the world, especially in Indigenous communities. We know that. That's why we're here. That's what we're working towards. And I hope that in this presentation, it's clear that we are in this together. Thank you so much. Really looking forward to the live question and answer that will follow this presentation.
Thank you so much, Renee, for that presentation and for all of our presenters. We will now open it up to question and answers. You may share your questions in the chat box. If you go to the section that says messaging, and I'm not sure if we're also opening it up for individuals to request to speak. Okay, so Wendy, you've requested to speak if you would like to ask your question.
Oh, thank you. Can you hear me?
Yes.
Yes.
Okay. Oh, hi, it's Wendy WISER. I'm in the territory of the Anishinaabe and the Haudenosaunee. I live about 20 kilometers north of Kingston on a farm, which is on a lake where the Shield meets the limestone bed. So where there was, in many years gone by, a sea up until meeting the Shield. So I really appreciate this session. Thank you, Trevor, for sending me a reminder to this morning. So I made it. As some of you know, I've been working with Trevor Stratton around TB internationally. I'm the chair of the Global Indigenous Stop TB Initiative. And Margaret and T and I met a while ago to talk about how to bring TB into CAAN. I guess I'll just put one plug in, is that tuberculosis remains the largest killer globally, more than HIV, both of Indigenous and non-Indigenous peoples. So I don't know if I have a specific question. Maybe I'm doing what Renee suggested to do. I'm putting in a plug. So anyway, I look forward to working with CAAN. I think there's a lot of interesting things going on, both in Canada and globally. So once again, thank you for your presentations today.
Thank you, Wendy, for putting that plug in for tuberculosis, TB, another dis-ease that Indigenous people on this land called Canada now have had to deal with for many years already, many decades. And so you know, being close to the place here in Saskatchewan called Fort San, where the hospital was, where my grandmother, my kokam, was. Stayed for I think several years, and had uncles and aunties also that were in there, and grandparents, right? So TB is nothing new to Indigenous people, but it certainly is one of those dis-eases that we have to take note of and to begin to look for solutions. So thank you for you know, Trevor, highlighting that within the CAAN family, and also for Wendy for bringing some of that information forward to CAAN, and we are looking at that and wanting to know as we move forward, you know, to address the multitude of dis-ease that we've had to look at from since this land was colonized and supposedly conquered. And so as we bring back the solutions for Indigenous people, we want to look for ways forward that are going to bring life to the people. And I so appreciate the presentations earlier that talked about the medicines in India. You know, those are beautiful ways, and also our own CAAN family who acknowledge the solutions in many different ways, from the animals and the plants and the land. Our relationship comes from the land. Where we'll see healing is when we have that relationship with all beings here on this land too, called Canada. So we're leading forward with high hopes and good hopes that as we move forward, we'll be able to look at the many other dis-eases that have came to this land. And when we get to the root of what is happening among Indigenous people, that's where we'll see the healing and the wellness arise. And we say, Wineska, wake up the people, in our language. So thank you so much for that.
Any other responses from our panelists? Okay, thank you, Wendy, and thank you, Marguerite. Our next question comes from Pilar Montalvo. What are the challenges in Canada to reach Indigenous peoples to speak about or advocate about HIV using technology?
I think that's a really great question. Thank you. Gracias, Pilar. In one of our research projects from many years ago, we actually did some analysis about how we find our community members communicate. And so Canada's a massive landmass. And so technology and the reach of internet, for example, is wonderful in the south and far more complicated in the north. This will perhaps be one of the stories of COVID-19 as we see greater emphasis being placed upon virtual work and virtual meetings and virtual medicine. There's ongoing political discussion about increasing connectivity across the land as well. But in our research, again, that was some years ago, what we heard very clearly was, while internet can be sketchy and it can be hard, cell phones, Facebook text messaging is pretty solid. And so I think that's also partly what may drive us towards thinking about social media as a potential platform. So, you know, short and sweet, which is, as Pilar, you know well, a challenge for me, but really learning how to package those key messages and to share those. So technology in terms of, I'll reveal my lack of understanding, but what I would call kind of maybe more simple technology in terms of cell phones, I think is actually a really great way to be able to reach our communities and our community members. And of course, there's also radio and amazing work that our partners have done around, you know, radio plays and so I think, again, when we think about how we work with media and learning to be more savvy about the way that we provide content to media and ask for media to work with us, there'll be some really great ways for us to work and working with, you know, what we would refer to as a mainstream media, but we also have some really, really fantastic media that works particularly and specifically with Indigenous communities and Indigenous-led media. So, you know, it's all of that kind of. I believe that as we learn the basics, we have the skill set and the experience as an organization to translate those basics to understand how we would use that to reach within our own communities, within Indigenous communities. And sometimes that means we have enough knowledge to know what questions to ask. So if, yeah, I mean, it's such an honor to have the opportunity to be part of this network. And as T mentioned, you know, all the different nations that the program's team members come from. And of course, that's reflected across our organization with all of our staff from many different cultures and perspectives. And so I think, you know, while I don't understand the traditions in T's territory, for example, I am aware that I should ask, what are the protocols here? I know that I need to respectfully, you know, before I come to the territory, that I should be checking in. I should be I need to understand before I just welcome myself in and come for a visit. And so I think that, I hope in the same way that as we do this training and we learn about some, you know, key strategies and tactics, that our understanding of working with our communities that has been growing and that we individually bring and that we've been learning as an organization, that will marry our knowledge of working, what we would say perhaps working in a good way with how to pick up these tools. And I think that's, I believe that's part of the resilience of Indigenous peoples, that we've learned how to survive and continue in this, you know, this evolving world by learning how to use tools in a way that's meaningful to us. And also how to use those tools in the mainstream so that we can, you know, be effective and meaningful in that context as well. It's heavy lifting, but I think it's work that we're doing, and that's why this partnership is so exciting to me, that we have this chance to kind of pull the curtain back a little bit and learn some of that context. So I guess still working on short-winded answers.
I would like to just respond to that question about technology. I think that your question definitely reflects that as Indigenous people, and our inherent right to our own self-determination is on multiple layers. And that's why we're looking at policy, at how do we create social policy reform in all avenues. And I think we've heard of things talked about of the social determinants of health. So when you look at something like connectivity for technology, that's part of who we are, our rights as Indigenous people. So we have to be all on board. And when we talk about we're all on board on this, there's many of us, the folks who are here today, we have a part, we play a part in this. And we take on that role and we take on that responsibility. There are other Indigenous people across this country who have different responsibilities, and that might be to look at technology, and that looks at where we can develop partnerships to ensure that our Indigenous communities have access to be able, so that we are self-determined.
Thank you for that, Renee and T. We also would like to remind individuals to participate in the poll. That is the evaluation. If you just click the polls button, there are 3 questions there for you to complete. We have a question from Trevor, and we have about 6 minutes left. But Trevor asks, how can we get the messaging right now that we've expanded the mandate to STBBIs? Does everyone know that STBBIs means sexually transmitted and bloodborne infections?
Is that a question to you, Margaret?
I'll answer it. As the newest, I've been in the position of the CEO since December 1st of last year, which is kind of ironic, December 1, World AIDS Day. But I've been working in this field for over 30 years, being in different capacities, right? And so I'm recently becoming the new one of the newest persons, but not the newest at CAAN. I look at all of these diseases that we're talking about. You know, the government wants us to name all of them, right? And they want us to put it in our mandates, and they want us to put it in our visions, and you know, in all of that. So we look at things like that, and I think about stuff. I think about those diseases, and I call them diseases for a reason, right? These aren't our diseases to carry. And as Indigenous people of the land, we have to look for solutions, right? And so when we talk about sexually transmitted infections, how many times in our field of work has the government changed some of the acronyms or the names of the diseases that we've been having to look at, right? And keep us in those silos. So as an Indigenous organization, CAAN, we're going to address all of these diseases in similar fashions, right? Through our medicines, our traditions, our culture, our knowledge, our ceremonies, our languages, and all of that, right? I always say this, as Indigenous people, we're compatible. We have our own doctors that sit along the Western way doctors, right? We have our own therapists, our own medicine people, all of that are compatible with what the colonizers created on this land. And so working together, taking the medicines and the medications is important, but to also acknowledge that first and foremost, we are Indigenous people. And how we look at sexually transmitted diseases, there's traditional medicines for those diseases now. And there's other medicines for some of those diseases that came to this land that we've had to address. I think HIV has taught us a lot of things around how we deal effectively with our own people, and how we have to, you know, look at what the colonizers have brought here to this land and address that we no longer, you know, we're supposed to, one of our laws that we talk about, and I think earlier in the session, some of the CAAN family talked about our own laws. As Indigenous people, we have our own laws, and we have to talk about Sakahitoan, which means love. And so we're told that we have to care about the spirit that lives in that person, in you, lives in me, lives in our Creator. Our creation stories talk about the Creator gave us a little bit of His own spirit. That's that fire that lives in us, our spirit that we talk about, that we feed mentally, emotionally, physically, and spiritually. So really looking deep and digging deep for those solutions. And you know, there's going to be other diseases that are thrown at Indigenous people, and we'll keep going. We'll keep looking for solutions. We'll keep working with what exists here on this land too, the ones that came here, because they are gifted too, and they have solutions. You know, all the other nations that are here, they have similar solutions. And it was beautiful to listen to India this morning and know that, you know, they're looking at their own ways too, their own ancestors, and how solutions have to be brought forward in those manners. So I'm just thankful for that. So yeah, we've had to change and I think CAAN is going to look at that pretty quick here. We're going to look at what we're doing and how to be more effective in terms of serving the people, right? The Indigenous people that live on this land, the ones that have been living with HIV, the ones that live with hepatitis C, the ones that have TB. I probably have TB in my lungs, but it's inactive because, you know, my immune system is okay. So, you know, I think about a lot of those things. A lot of us probably have TB in our lungs. You know, we don't know it because it doesn't impact us because our immune systems aren't, there's, you know, nothing going on with our immune. We've got good immune systems. So those are things that I think about, and I'm on track. Yeah, thank you so much. And I appreciate, you know, working together as a family, increasing our membership at CAAN, bringing in people that will help us to bring those solutions to life is important for our programs, but also for our research, right, as we begin to navigate through what we're experiencing. Thank you.
Thank you, Marguerite, and thank you to all of our presenters today. Akila Rajasra, Pandi Ramesh Babu, Marguerite Kasika Paisis, T. O'Donnell, Celine Albin, Marnie Amaro, and Renee Mashing. I'm your moderator, Savannah Jean. And also thank you to our interpreters and the technicians at Kudu for all of your hard work. This WISER webinar series has been brought to you by the International Indigenous Working Group on HIV and AIDS. WISER stands for Weaving Indigenous Stories of Experience and Resilience, our vision for Indigenous health. Originally, this was supposed to be a 2-day in-person 8th International Indigenous Pre-Conference on HIV and AIDS, but due to COVID-19, the Pre-Conference Planning Committee decided to convert it to the WISER webinar series. And this has 11 sessions that began on July 3rd and 5th with a 2-day event leading up into AIDS 2020. The WISER webinar series is now continuing. It continued through the month of July 11th to the 30th. There are 2 more left on July 28th and 30th with a great closing session. Attendance for all of these sessions are free, and the webinars feature simultaneous interpretation in English, French, and Spanish, and are available on the website. All of these presentations are recorded and will be on the website again, and the presentations that we may have missed will also be included in that recording. Thank you so much for all of the presentations and for all of the individuals who participated in today's session.
Thank you, Savannah.
And with that, we wish you a great day. And again, thank you.